and welcome to today's webinar, Congenital CMV, Standards of Care, Knowledge Gaps, and a Story. I'm Christy Jewell of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by DiaSorin Molecular. To learn more about our sponsor, please visit molecular.diasorin.com. Now, we encourage you to participate today by submitting as many questions as you want at any time you want during the presentation. To do so, simply type them into the Ask a Question box to the left and click Submit. We will answer as many of your questions as we have time for at the end of the presentation. You may also use this Ask a Question box to let us know if you're having any trouble seeing or hearing the presentation. I would now like to welcome our speaker for today's webinar, Dr. Laura Gibson, Associate Professor, Departments of Medicine and Pediatrics, UMass Chan Medical School. For a complete biography on our speaker, please visit the Biography tab at the top of your screen. Dr. Gibson, welcome. You may now begin your presentation.
Thank you so much for the invitation. Good afternoon, good morning, everyone. I'm excited to be here, and I am hoping that you become as interested in congenital CMV infection as I am through the course of my discussion. So a few disclosures. I work with Moderna Therapeutics. I'm a member of their scientific advisory board and receive some research funding from them. And I'll be talking about some off-label uses here. So our learning objectives are to understand the standard of care for congenital CMV diagnosis, evaluation, and treatment, to recognize areas of care for which evidence is lacking, unclear, or pending, and gain awareness of the family experience and the impact of their CCMV advocacy work. So we'll start with that family story. This is a family that I took care of when their baby was in the NICU, the neonatal ICU. So this is Vanessa. At the time, she was a 28-year-old woman. She was pregnant with her second child, uncomplicated. In particular, no febrile illnesses. Her lab tests were normal. Her ultrasounds were normal at 9, 12, and 18 weeks. She went to the emergency department at about 25 and a half weeks after a minor fall in her backyard, just as a precaution. But an ultrasound at that time showed a few abnormalities, borderline prominence of the lateral ventricles, and that's the ventricles are fluid-filled structures in the brain. Echogenic bowel suggesting inflammation, and a small pericardial effusion which is fluid around the heart. So she lives with her husband, an 18-month-old child. There's Sam, a picture of Sam, and she's an elementary school teacher. So one of the first area of uncertainty that I'll highlight of several throughout our discussion is that there's no ideal or perfect way to diagnose CMV in pregnancy. So there are a number of different types of infection, CMV infection. Primary infection when someone gets the virus for the first time. Reinfection when they get a new virus on top of the one they already have. And reactivation, which is the virus comes out of dormancy and becomes active in the body. So currently screening for CMV in pregnancy is not recommended, and that's because of a number of reasons. And we'll go over a bit later diagnosis of CMV in pregnancy, but there's currently no standard of care, at least in the US. Some other countries do this regularly, but there's no standard of care for screening for CMV in pregnancy. So a few words about cytomegalovirus itself. So the herpes virus family contains several viruses. They all have some commonalities. They have a large and complex genome. They have a typical virion structure you can see here in the top left, where regardless of the different viruses, they all have that structure. And they're all characterized by latency or dormancy in the body with intermittent reactivation, where, as I said, the virus becomes active in the body and basically wants to do that in order to pass on to the next host. So there are, as I said, a number of viruses in the herpes virus family. Herpes simplex, so they're actually divided into subfamilies, alpha, beta, gamma, and they contain a number of viruses that most of which you might have heard of: herpes simplex virus, varicella virus, which is the chickenpox virus, CMV is a beta herpes virus, and then EBV is the monovirus down at the bottom, which is a gamma herpes virus. So they all originally started with the name human herpes virus and then a number. So HHV5 is what CMV is technically or historically. So they all transmit in some sort of body fluid. So looking at CMV, the CMV is typically spread through saliva, genital secretions, urine, breast milk, and blood. So the virus likes to get to one of these body fluids so it can pass to the next host. And the different viruses are latent in a variety of different places. So CMV in particular is found in some immune cells and inside the lining of blood vessels and in glands like the salivary gland and the kidneys. So a few basic numbers that are important to understand. Not quite half of women of childbearing potential have CMV already if they become pregnant. So not quite half of women have the virus already, and the other half have never had it before as they become adults. So about 2% of all seronegative pregnant women, meaning seronegative means their antibody is negative, their IgG antibody, and that's called seronegative. So about 2% of seronegative pregnant women get CMV for the first time during pregnancy. In that case, the risk of transmission to the fetus is about 30 to 40%. So most of the time, the virus does not transmit to the fetus. But in non-primary infection, we do not know the risk of transmission to the fetus. So what I mean by non-primary infection is those other two types of infections I mentioned earlier, which is reinfection, so a new virus on top of the one that someone already has, or reactivation, which is reactivation from latency into an active form within the body. And so the reason we don't know much about these types of infection involving people who have had CMV in the past is that the way we diagnose CMV infection, at least primary for the first time, is seroconversion from negative IgG to positive IgG. But in people who have already had CMV in the past, they already have a positive IgG antibody. And so we have no way, we don't know how to measure these other two non-primary infections. And that's a particular challenge when these individuals are pregnant. So overall, the incidence of congenital CMV infection is about 0.6 to 0.7% of all live births every year. And this is a number that's pretty consistent across the world in countries where it's been measured. So looking at the United States for live birth data, the most recent available is 2019. About, if we calculate 0.6% of all of those live births, that's over 22,000 infants in the US that were born in 2019, and that's approximately the number every year. And then thinking more about Massachusetts, which is where I am, that translates to over 400 infants in Massachusetts born in 2019 with congenital CMV. The problem is that we don't know who they are. And we'll talk about neonatal screening a little bit later. So if we're looking at all causes of sensorineural hearing loss in children, CMV is responsible for about a fifth of all hearing loss in children. So it's the most common non-genetic cause of hearing loss in children. It's also very clear that the effect or the burden of disease of congenital CMV varies by race and ethnicity. So the birth prevalence of congenital CMV is higher in Black and multiracial infants, and it's quite a bit higher compared to other races and ethnic groups, Hispanic whites, non-Hispanic whites, and Asians. So significantly higher in Black and multiracial infants. And the adjusted or unadjusted prevalence odds ratio is much higher, up to 3.5, and then around 2 for the adjusted rates. In addition, CMV infected infants are more likely to be Black and have public or no health insurance compared to non-infected infants. So these are the numbers here, and in this pretty recent epidemiologic study that in 50% of CMV positive infants, for example, are Black compared to CMV negative infants at 24%. And 82% of infected infants have public or no insurance compared to 64% for CMV negative infants. And there are several other studies that show these racial and ethnic disparities. So if we look at primary infection, meaning who's getting CMV for the first time, here we have the rate I was talking about earlier of pregnant women. So about 2% of pregnant women get the virus for the first time every year. This 1 or 2% is the general public, which is blood donors is the easiest way to measure CMV in the general public. There's one particular risk factor for individuals to get CMV for the first time. So parents of infants who are shedding CMV, and what that means is they have a lot of virus in the saliva or urine. So exposure to those body fluids is a high risk of transmission. So parents who have a young child with CMV in the urine or saliva get CMV, they have a 24% risk of getting CMV every year compared to 1 to 2%, as I said, in the general public. Daycare providers, so these are individuals who work with children in a childcare setting, or parents or childcare providers or parents who are exposed to children possibly shedding CMV. And so in childcare, a large number of children could be shedding CMV at any time, because CMV is one of those infections that goes around large groups of children, like many other infections we know about. And so even if we don't know whether the children are shedding CMV, those providers or those parents seroconvert at about 8% per year. And then the seroconversion rate in women in high seroprevalence communities, meaning communities or countries where nearly all individuals have had CMV in the past at a very young age, which is different from the 30 to 50% seroprevalence that I was talking about earlier. So the rate of new infection or reinfection, or even those small number of women who are seronegative, they get the infection, CMV infection, at a very high rate as well, because there's a lot of virus going around a community where most people are, or the vast majority of people are infected already. So what's the burden of congenital CMV disease? If you look at children, the number of children who have these various pediatric conditions every year, and the conditions include HIV, fetal alcohol syndrome, Down syndrome. Congenital CMV disease is right at the top in terms of number of children affected per year. And if we look at the screening programs that we have already, so the newborn screening program, it involves a dried blood spot, and these are on the x-axis are all of those conditions that are in the newborn screen in that dried blood spot. And we, cystic fibrosis, metabolic disorders, all of those put together result in diagnosis of about 6,400 infants per year. So the hearing screen, which is done on all babies before they're discharged from the hospital when they're born, the hearing screen identifies about 5,000 infants per year with potential hearing loss. But if we were to have a newborn screening program for congenital CMV, we would identify more infants than all the dried blood spot testing combined, or all the hearing screen testing. So that CMV screening of newborns would have meaningful benefit to at least as many children as are already helped by existing newborn screening programs. Unfortunately, the degree of CMV awareness among women, this is a study performed among women, the percent who had heard of each of these conditions here on the y-axis, fetal alcohol syndrome, SIDS, Down syndrome, despite the very large birth prevalence of congenital CMV, only a small minority, 13%, had ever heard of CMV or congenital CMV. So a bit about transmission. The risk by gestational week does vary. So on the x-axis is gestational week. These weeks are those before conception. The red arrow is at conception. So the average is the black line. There can be CMV transmission to the fetus if primary infection occurs in the pregnant individual before conception. So the lowest rate of transmission is in the first trimester, and the highest rate is in the third trimester. So this is where the 30 to 40% average is depicted. So there are a number of things that are predictive of CMV transmission, meaning in studies where women are identified as transmitting or not transmitting the virus. So depending on what antibodies they have, depending on what T cells they respond with, those can be associated with risk of fetal transmission. So a number of things are not predictive, meaning it doesn't matter what these values are. We can't say anything about the risk of transmission. So it doesn't matter what the severity of maternal symptoms are. Most of the women that I've seen, almost all of them have said, no, I was never sick during pregnancy. And it doesn't matter the amount of virus in the blood in terms of the risk of transmission. So we don't have good biomarkers of risk of transmission for pregnant individuals. And as an illustration of how the virus transmits, or at least the cell types that might be involved, here's a picture of the maternal fetal interface. And so on the right is the uterus side, which is the maternal side. On the left is the placenta, which is fetal tissue. This sort of columnar structure is an anchoring, called an anchoring villus, and these cells intercalate into the uterus. And this structure over here is similar, but a floating villus. It doesn't extend into the uterus. These red cells depict CMV infected cells. And so they can become infected and pass through to the fetal side from maternal endometrial glands cells, lymphatic vessels, uterine blood vessels. So they're all mixed together here. And so the virus infected cells can cross over into the fetal side. At the same time, the protective effect of maternal immunity, so certainly there's maternal immunity at the maternal fetal interface. There are a number of immune cells, although this is it's a immunodeficient milieu in that location. So the protective effect of maternal immunity on CMV transmission is unknown, meaning we don't know how much it helps to have had CMV in the past when someone is pregnant, meaning there's some immunity, versus getting CMV for the first time during pregnancy. So if we take 1,000 non-immune women, 100% are susceptible, and we just mean that they have not had the virus before. They convert in this study about 3% per year. There's a 30% transmission rate or so. And that calculates out to a birth prevalence of 0.9% in this study. So pretty close to the 0.6 to 0.7%. If we're looking at 1,000 immune women, meaning they've had CMV in the past, we don't know what susceptible means. We don't know the number of seroconversions because these women are already seropositive. We don't know how to measure this. So we don't know how to measure reinfection where they might have acquired a new virus. We certainly don't know the transmission rate. We don't have any way of measuring that because we can't identify the women. But we still see a birth prevalence about 1.2%. So that means the birth prevalence, or the number of infants born with CMV infection to seronegative women or seropositive women, is about the same. And this was one of the major findings in the last several years, at least 5 years. So you might hear a comparison between, the risk of transmission is 30% in women who are seronegative, getting the virus for the first time, and 1% in women who have had CMV in the past. The problem is that these are not the same. These are apples and oranges. Really, the comparison is between the birth prevalence. So comparing the birth prevalence, really the same number of infants are born to both types of women, seronegative and seropositive. So it's important to remember that. Certainly, CMV immunity is likely protective. We just don't know the degree to which it's protective. So as we were talking about earlier, prenatal diagnosis is it can be done, prenatal diagnosis, and that means prenatal diagnosis of primary infection. As I said, if CMV IgG antibodies already positive, we can't do maternal serology, because what we're looking for is an IgG and an IgM done on an ELISA. The IgM is confirmed on a Western blot. If these two tests are positive, we can do an IgG avidity study, which basically looks at how strong the antibody binds to the virus. Fetal diagnosis occurs by amniocentesis. So we do CMV PCR on the amniotic fluid. It really cannot be done before about 20 to 21 weeks of gestation, because there needs to be robust fetal urine mixed into the amniotic fluid, and that's where the virus is during pregnancy and when infants are born. There's a lot of virus in the urine, and the amniocentesis needs to be done at least 6 weeks after maternal infection, which we usually don't know, but because it takes time for the virus to get into the pregnant individual, circulate, get across the placenta into the fetus. So there's some risk of false negative results if an amniocentesis is done before about 20 weeks, or if it turns out that there was maternal infection less than 6 weeks previous to the amnio. Fetal blood can be tested, but that's rarely done. The IgG avidity, a bit more about this test. So the IgG avidity can only be done if the IgG is positive. So we can't do this on a person with an only IgM positive. It's a test we do routinely to see if primary infection has occurred recently or a long time ago. And this test allows some probability of understanding that, because the question is, did primary infection occur during pregnancy or after conception, or did it occur quite a while before conception? And so if the IgG avidity is very low in this red box, there's a 98% positive predictive value. So we can be very sure that if the IgG avidity index is very low, there's a 98% positive predictive value that primary infection occurred within the previous 3 months. So that's a very helpful test result. If the index is intermediate or high, the negative predictive value is about 88% that primary infection did not occur in the previous 3 months. So this is when the binding is stronger, it means the infection occurred in the more distant past. The problem is that most of the women I think I've ever seen with this test, it's somewhere in the middle. So we're really guessing, you know, when did primary infection occur? And it's often, you know, a complete estimate of, was it 3 or 4 months ago? Was it not? And this is the struggle we can get into with prenatal diagnosis. So getting back to our family, Vanessa had a couple of ultrasounds after her first one in the emergency department, and she also had an evaluation for congenital infections, and her CMV testing showed IgG and IgM positive, which is what we're looking for to consider the diagnosis of primary infection. The ultrasounds showed at 26 and 27 weeks a number of very concerning findings. Severe IUGR, intrauterine growth restriction, where the estimated fetal weight was only about 5,500 grams. That's hardly a pound. Enlarged heart, the brain was normal. And then these conditions are particularly concerning: spontaneous decelerations of the fetal heart rate, and particularly reverse and diastolic flow in the umbilical artery. So then congenital CMV disease has a number of findings on physical exam, and this is in general. A number of them are listed there. You might have heard this disease called the blueberry muffin syndrome. And the reason for that is some infants can be born with these sort of purplish lesions here, which is different from this sort of darker red rash, which is due to low platelets and bleeding in capillaries. These purplish spots here happen in the skin because they're here, and it's called extramedullary hematopoiesis. This happens because the virus is so suppressive of the fetal bone marrow that the bone marrow cells distribute into the fetal tissues and set up in the skin in particular to try to be sort of metastatic bone marrow to generate the cells that the fetus needs. This is a very rare finding, but it's a typical finding of congenital CMV. So then if infants look like this at birth, why is there a discussion going on in the field about CMV newborn screening? Meaning testing most, if not all, infants, regardless of how they appear at birth. So the rationale for newborn screening, it provides parents knowledge, support, and resources. It may explain abnormalities that develop later in childhood. There's limited capacity for retrospective diagnosis, going back to the dried blood spot. One of the most important things is that it initiates an evaluation that would not be done otherwise for infants that appear normal at birth. We monitor hearing and neurodevelopment, even if treatment is not pursued. It qualifies infants for a variety of services, even if they appear normal at birth, at least in Massachusetts. And certainly there's an opportunity for research and availability of future interventions. So an area that we don't know about in terms of a national or statewide screening programs, we don't really know the cost effectiveness. There have been several modeling studies that have shown cost effectiveness, but no rigorous sort of measuring the cost of screening. And we don't know if it's beneficial to know if infants who appear normal at birth, which is most of the congenitally infected infants, we don't know if it will be helpful for them to have a diagnosis of congenital CMV. And the reason that some people argue that that's a risk is that those infants may go through procedures they don't need, or carry labels they don't need in their health record, or otherwise, not benefit from having the diagnosis. So we don't really know the answer. The rationale, there's much more rationale than I've shown, but there aren't good studies to show that there's no risk to, or low risk of screening to asymptomatic infants. So how do we screen? The typical test is the saliva. We do a CMV PCR. And if that's positive, we do a urine PCR. And that's because the positive predictive value of a saliva PCR is on the lower side. And usually our false positive results result from breast milk or other contamination into the sample. Diagnosis has to be made within 3 weeks of age, because after 3 weeks of age, the virus could have been acquired after birth, say from siblings or family contacts or childcare settings, et cetera. So the diagnosis has to be made within 3 weeks of age. There are a couple of types of newborn screening, at least two that we refer to in the present. One is targeted screening, meaning there's an abnormality from which because of which a CMV screening test is done for an infant. And this is often most commonly targeted to the newborn hearing screen. So a failure of the newborn hearing screen would prompt a CMV PCR test. Universal screening is where all infants are tested at birth, similar to the dried blood spot, which is done in all infants. So the congenital CMV was nominated to the recommended uniform screening panel a few years ago. It's still with the RUSP now, and that process is continuing. States don't have to follow the RUSP list of conditions, but most do. Several states, actually it's mainly Connecticut and Minnesota, the New Jersey laws pending for the future. Minnesota and very recently Connecticut passed universal screening laws so that all infants in those states are screened. We have a pending law in Massachusetts and in Indiana. And actually a couple months ago, one of the Connecticut senators submitted a federal law requiring congenital CMV screening on all infants. So we really are at an early stage of this process. We don't know logistics of state or national implementation. Certainly it varies by state. Many states, 17 or 18 states, have targeted screening laws. Only 2, Minnesota and Connecticut, have universal screening laws. And we don't know the impact of all this screening on primary care practices, on departments of public health, but we're learning as we go along. So at UMass, we have a protocol that involves targeted screening based on hearing screen results, as I said, and that's in the newborn nursery. In the NICU, babies born at more than 34 weeks gestation also get the same targeted screening. But we screen all infants born less than 34 weeks because they don't have their hearing screen before 3 weeks of age when the congenital diagnosis needs to be made. So we screen all infants that are admitted to the NICU at less than 34, if they're less than 34 weeks. So going back to our family, Vanessa, based on that most recent ultrasound, was taken emergently to cesarean section. The APGARs for, this is baby Logan, the APGARs were very low. That's a measure of infant well-being at birth. He required significant resuscitation. He had a number of abnormalities on physical exam. Very, very low, critically low platelet count, critically low neutrophil count, and his saliva PCR was positive for CMV. And again, he had fairly large lateral ventricles, meaning there was more fluid than was normal, but otherwise the brain was normal. So the most challenging thing about seeing these babies, and I typically will leave at least 2 hours of time to spend with families with a new baby with congenital CMV in the hospital or the office. Every single one of the parents, or at least the women I've seen over my entire career, has said some version of, why didn't anyone tell me about CMV? If I had only known, then I would have done things differently. And this is what prompts many of us to continue making progress in the field toward eliminating some of the agony that we see in parents. CMV can be so easily preventable. So Vanessa, we looked at the placenta of Vanessa after birth. It showed clearly these viral inclusions. They're viral particles inside of cells. She also had various other markings of congenital infection of the placenta, which is these very large, huge blood vessels in the chorionic villi. These are in cross section. As they dilate to allow more blood into the fetus because of viral infection of the placenta, which is not working well. We also stained the placenta for virus, and it was clearly positive, shown by these dark cells. And here's a comparison of baby Logan and how small he was at the time of birth, extremely low birth weight. So of these children that are born with congenital CMV, what happens to them? What are the possible outcomes? So most are asymptomatic at birth, and what that means is they appear normal on physical exam. It does not refer to the additional evaluation and testing that we do. If a child who appears normal is diagnosed with congenital CMV, or at least if their hearing screen is abnormal, they go on to have this evaluation. So asymptomatic just means they appear normal at birth. And on the order of 10 or 15% are symptomatic at birth. Congenital CMV has about a 0.5% mortality. And if you combine all of these, whether asymptomatic or symptomatic, of all infants with congenital CMV infection, 18%, this is overall, if you combine this number and this number, have permanent disabilities, and those are hearing loss or neurodevelopmental disabilities. And 75% are born to seropositive women, again, showing us that all pregnant individuals are at risk of congenital CMV, whether they've had CMV in the past or not. We don't have really any good ways of predicting prognosis for parents. So this is a very interesting study where this study and data from a couple of other published studies looked at head imaging in various types of head imaging and neurodevelopmental outcomes. So the sensitivity of ultrasound, CAT scan, MRI, or CAT scan in all of these studies resulted in a sensitivity ranging from 8 to 13% up to 100%. So we have no idea how sensitive these are. They really vary based on the modality and the radiologist. There's more consistency in negative predictive values. So really the best prognostic factor we have is if head imaging is normal. That is a very good, has a high negative predictive value that there will be normal neurodevelopmental outcome. But we don't know the significance of isolated or mild findings, which is very common. We usually do ultrasound, and we don't know if there's a benefit to MRI, and we don't have any other biomarkers for prognosis. We also, there are also, and I won't go through this whole study, but head imaging is, whether it's ultrasound or MRI, is best in terms of predicting hearing outcome, is best if the imaging is normal. So normal head imaging has about a 90% negative predictive value of for hearing loss, meaning it's very unlikely that there'll be hearing loss, but not delayed onset hearing loss. So hearing loss can develop later. So we only have this association in early hearing loss, not delayed. There are antiviral drugs to treat CMV. As you recall, the virus stays with us for life, so it doesn't get rid of the virus. But these viral medications can keep the virus under control for a period of time while additional tissues in the newborn are growing. We don't have a predictor of long-term benefit. Yes, there are clinical trials, but those predicted benefits are variable, and they certainly don't occur for all infants. So this is to show you that we have clinical practice guidelines. These were published by a group of us in 2017. They're in need of updating. And basically they say that infants who are asymptomatic or only have hearing loss, there is no evidence that they benefit from treatment. And infants who are moderately or mildly affected would likely benefit from treatment. So I think I'll kind of go through this quickly. This is the study that, the clinical trial that tells us what the current standard of care is. And the problem with this study, certainly it provides guidance on what we should be doing in terms of standard of care and treatment, but it doesn't tell us how to treat infants that do not fit the inclusion criteria. So baby Logan was well below 1,800 grams and at a gestational age well below 32 weeks. So we give the drug, still give the drug, according to this study. I'll kind of run through here. Orally, so we give valganciclovir orally for 6 months. But we don't know the benefit of treatment for those other infants, so those with no or mild symptoms, with isolated or late onset hearing loss, meaning no other abnormalities, and with sort of global issues like prematurity or small for gestational age or small weight at birth. So let's go back to Logan's course. I'll describe this graph. On the x-axis is time in weeks. Up at the top is his course of the different treatments that he was on. And the colored lines are the, in green, the ANC, that's the absolute neutrophil count. in purple, the direct bilirubin, and in gray, the CMV viral load. So how much virus was in the blood. So when Logan was born, he was treated with ganciclovir right away. He was very sick at the time. And he had very high direct bili, meaning liver disease. He had very low neutrophil count, as I said, around 200, which is severely low, all of which improved on the treatment. Then he developed his liver got better, but his blood counts got severely worse, down to 0. He had no white cells in his blood. So we had some trouble with starting and stopping the drug and wondering if the low blood counts were due to virus or drug, because this is a side effect of the drug. And so we stopped the drug. The blood counts got better. The liver continued to get better. The virus was very low. But later on, the virus increased. So we changed to the IV form. Liver had some trouble. Blood counts better. So he was stable in this period of time. So very stable, doing quite well. At about this point, he became very sick again. Hepatitis, pneumonitis, neutropenia. And his viral load was highest we'd ever seen it, at about 7 million copies. So back here with this virus level coming up here, we checked the resistance to ganciclovir, which was negative. And when the virus went up to this very high level, we tested the resistance, and it was positive, meaning there was drug resistance to ganciclovir, the drug that was being used. So changed to foscarnet, another drug for CMV, and the viral load went down very nicely, very quickly. And the blood counts came up very nicely. So a good response to that viral medicine. As we were doing that evaluation, we did an MRI of the brain to get an update on Logan, how his brain was doing. And he had very severe abnormalities, an incredible loss of brain tissue, as shown in a number of these places with arrows. Most of this dark area is fluid that should be brain. There's a huge amount of brain loss here as well. So this was very severe brain damage in a child who was becoming very critically ill, needing full life support at that time. So Vanessa and Peter decided to direct Logan's care to comfort measures, and he passed away of congenital CMV at about 4 months of age, and there's baby Logan not long before he passed away. This was a very difficult decision for them, as you can imagine. But Vanessa and Peter have gone on with a number of us, a multidisciplinary group, to develop or found the Massachusetts Congenital CMV Coalition. This is back in 2019. We are the ones that filed the bill in the Massachusetts legislature for universal screening. We're also doing advocacy work with the Massachusetts Medical Society and the Department of Public Health, a number of ways to advance the field in Massachusetts. So I can answer more questions about that if people are interested. So in summary, awareness and knowledge of congenital CMV is low. Birth prevalence is equivalent regardless of maternal CMV history. The burden of disease is higher than many well-known pediatric conditions. Universal newborn screening and diagnosis allows education, evaluation, monitoring, treatment, guidance, support, and research. And parent and family advocacy leads to change. Thank you, everybody, for listening.
Dr. Gibson, thank you so much for that informative presentation. I would like to now start our live Q&A portion of the webinar. And to our audience, if you have any questions you would like to ask, please do so now. Just type them into the Ask a Question box and click Submit. We will answer as many of your questions as we have time for. And Dr. Gibson, we have quite a few questions already coming in, so I'm just going to dive in here. Let's start with this first question. What would be your gold standard for testing in neonates and newborns with blood, urine, or saliva?
The regimen of saliva screening and then a urine test, these are both PCR, for confirmation of a positive saliva is a protocol that works very well. The blood testing or dried blood spot testing is not ready for screening. So that's, I wouldn't advocate for that. Although some people do that, it can certainly be done in retrospect. But the sensitivity isn't high enough at this point for blood.
Very good, thank you. Next question. Can a woman suffering from mouth breathing, nasal discomfort, be affected by a virus given that this chronic pathology? Therefore, will her baby suffer from the same situation as her mother?
I'm not sure that has to do with CMV in particular, because nasal or mouth breathing isn't a symptom of CMV in adults or in children that we would typically see.
Thank you. And Dr. Gibson, what FDA cleared PCR assays are available for congenital CMV testing?
So there are a few, and at least Meridian has one, and I don't know if your test is Diasorin's test is FDA cleared. I think it is, but of course you'll know the answer to that.
Thank you. And is there any type of immunization available soon for this?
Not soon. But the good news is that many more companies now compared to, I don't know, 5 years ago, have a CMV vaccine platform. So that's great news for progress.
Very good. And I do want to note that the Diasorin molecular is approved.
Yes, I thought it was.
Thank you. So Dr. Gibson, lots of physicians say that if the CMV can be transmitted in primary or non-primary infection, what is the usefulness of screening pregnant women?
There isn't a lot of usefulness right now, and that's why it's not recommended as standard of care. One of the reasons is that, yes, all we have for prevention right now is behavioral behaviors to minimize contact with body fluids with virus in it. And so that information should be given to all pregnant women, regardless of their test result. So that's one reason that the test isn't typically done. Other reasons include, as I said, the results are often confusing. And there's no current intervention during pregnancy to prevent transmission of the virus from the pregnant individual to the fetus, regardless of what the test results are. So there are a number of reasons that it's not recommended.
Thank you. And I do want to clarify one more time that Diasorin does have a PCR 510K cleared assay with both urine and saliva sample types. And I do think we have time for one more question here. Children at which age shed most of the CMV DNA?
Usually at birth, but it can be weeks, months, or even years before they clear. So certainly they all have it at birth in very high amounts, and then they clear it at various times after that.
Very good. Thank you. And Dr. Gibson, we are just topping the top of the hour. So do you have any final comments for our audience?
Again, thanks everybody for coming, and I'd be certainly happy to answer questions offline if there are any more.
Very good. Thank you so much for your time today and your important research, Dr. Gibson. I do want to thank LabRoots and our sponsor, DSO and Molecular, for underwriting today's educational webcast. I do want to thank our audience also for joining us today and for their interesting questions. We do have quite a few questions that weren't answered, and your questions that we didn't answer today, and additionally, those questions that come in during the on-demand period, they will be answered via the email address you provided at the time of registration. Today's webcast can be viewed on demand. A few of you submitted some questions asking about that. It will be available for replay in about approximately 1 hour, and LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. That's all for now. Thank you so much for joining us. And again, Dr. Gibson, thank you for your time today.
Thank you.
Have a great day, everyone.
Bye, everybody.